Thanks so much to the organizers and President Obama for inviting me to present at this exciting workshop. I'm Dave Kaufman. I'm a program director at NHGRI in their Division of Genomics and Society. And over the past 8 weeks, a team that I've been working with has examined and summarized a number of the key cohort studies in health systems in order to sort of just help assess whether there might be sufficient resources out there that realistically could be used as part of the precision medicine cohort. This inventory, like this Michelangelo sculpture, apologies to the artist, is unfinished, but the inventory does show some recognizable features. We are not presenting an exhaustive summary of all the studies that could be leveraged. What we have done is an early assessment of the landscape in order to just see what sort of numbers are there of participants enrolled, where are they located, what are their demographics, how many of them have broad consent, are being actively followed, have biospecimens stored, what's the willingness of these studies to share data, and to what extent are they linked to EMRs. We used a very, very simple methodology. We combined 4 existing lists of cohort studies, one that Terry and my other colleague Jeff Struing put together. We combined these lists of, sort of important and interesting cohorts, resulted in a list of about 205 studies, and just again to give us a slightly smaller starting point, we triaged this list by looking for studies and health systems that were commonly cited, that have been established for some time, that clearly are currently active in tracking following participants, sites that we could tell participate in collaborations and consortia, and also some studies that focus on the recruitment and retention of understudied population. And we just tried to get information on the characteristics above using the internet and just talking to some PIs. So we looked at 3 major types of resources. Longitudinal research studies, or I think this might be what George is sort of calling old studies, the older cohorts. And within the 53 studies we looked at, there are about 5 million people. We also looked at 10 research-oriented healthcare systems that contain 7.3 million people, and then a few hospital-based cohort studies that are, I think, maybe examples of what might result if you use the research-oriented healthcare systems, and there were about 1 million people in those 6 studies. And the longitudinal research studies, the sort of, one of the defining characteristics of them is that they have, highly structured, well-defined data that's been collected explicitly for biomedical research. And, as we've already heard, the healthcare systems have broad phenotypes on lots and lots of people, and most of them are linked. Most of them have that data in EMRs, making it very easy and exciting to possibly use. But some structure may need to be added in order to use them. So overall, we looked at 69 studies in health systems, 13 million people in all of them. 11 of those studies had less than 1,000 people. 22 of them had more than 100,000, and the median size was 51,000. Looking at the funding sources, NIH had funded studies that contained 6.3 million of those participants. You can see some of the major institutes that have been participating in creating cohort studies, NCI, NHLBI, and a whole host of others. 2.8 million of those people were in the longitudinal studies. So NIH is involved in funding or providing funds to some of the healthcare systems as well, and I mean, as most of you well know. Other important funders, DoD funds lots of different cohorts, including one with about 220,000 people in it. The VA, of course, is doing its Million Veterans project. The American Cancer Society's long been involved in very large cohort studies. And of course, again, the health systems who have invested in their own databases and biorepositories. Just looking quickly at geography, these are the sort of, single site local studies, 40 of the 69. Not surprisingly, there's a lot of concentration on the coasts and the upper Midwest. And then there are, a host of national cohort studies that make up about 5.6 of that 13 million. And the one thing to take note of is these national cohort studies don't necessarily, none of them are really getting, or most of them are not getting nationwide participation. Most are recruiting from, between 4 and 50 different centers. And so we need to remember that as we think about getting representation from different areas, that even the national studies may not sort of meet all those needs. Just looking at the age distribution, we just got ranges and medians from 29 of the longitudinal cohorts. And as you can see, the sort of all of the decades of life are sort of covered here. These cohorts do skew a bit older, and we could argue whether older is actually better in some ways, because we're interested in a lot of chronic diseases that occur late in life. But so the median of the medians here is age 65. Looking a little bit about the representation of underserved and understudied groups, these numbers reflect only a small portion of the actual numbers in the 69 studies. We basically drew the numbers from the studies that were focused on recruiting from these populations. Basically, we just haven't collected the demographic data on the other big studies. So these numbers are probably not adequate to populate the precision medicine cohort, but we should take note that these studies that have focused on working in these populations have extraordinary amount of experience engaging the community, recruiting them, and retaining them. And so we may want to consider them as partners. So just looking at the criteria that we might want from a study as we think about incorporating them into the precision medicine cohort, one of the big ones is whether or not they're actively following the people. We want to be able to see what happens to them next and get new data from them. And so 58 of the 69 studies are either following up or have the ability to recontact. About 9.5 million people, 2/3 of those are in those hospital studies and health systems. In addition to the ability to follow up and recontact people, we'd like studies to have biospecimens available, and we'd like them to be broad sharers. And it's sort of difficult to define broad sharing, but we asked a lot of the PIs what they do, and we were looking for studies that allow researchers from outside to apply for access to the data, that are contributing to dbGaP, that are entering into a lot of consortiums, and that of course have consent to broadly share their data. So the intersection of these three, again, in our group, there were 32 studies in healthcare systems. I think this is sort of the best case scenario, again, within the group we looked at. Between about 3 and 6 million people meet all three in the studies that meet those three criteria. We also looked at some value-added characteristics that would allow sort of, I think, some early research and early gains as the cohort sort of comes up to speed and ramps up to whatever it is that we are actually going to build. Broad consent, about 36% of the studies said that they have it. 2 and 3 have done some genotyping, and 1/4 have done at least some exome or genome sequencing. And 1/3 of the longitudinal cohorts said that they're linked to EMRs. Half of those are using linkages to Medicare data. And most or all of the healthcare systems, as Dan said, are also using EMRs. So other potential resources, again, we looked at 70 studies. We have 130 more on our list that we honestly have hardly touched. And of course, there's a good 100 to 200 out there that we haven't looked at. Other large-scale consortia, the HMO Research Network, the NCI Cohort Consortium, and PCORNet, these aren't necessarily, there's a lot of overlap, the people that we looked at with these groups, but But these are important sort of lumpers that I think we can learn a lot from. These independent large-scale efforts from patients like me, 23andMe, Sage Bionetworks, and Google, not only are they looking at large numbers of people, but I think they can be sort of disruptive as we think about information flow and usage. And yep, I got one more slide. And of course, and biobanks. And just a few quick words that I heard from the cohort PIs as I was talking to them. There's a lot of enthusiasm for this. Reconsent is possible, but not very practical. They have a lot of experience already harmonizing their data, and a lot of engagement is going to be needed. Thanks so much to everyone. Thanks, Terry, for your indulgence.
Thank you very much, David. Sorry to interrupt you.
No.
Do we have any clarifying questions that anyone would like to address to David? Yes. I'm glad I let you go.
Off the hook.
All right, great. Thanks a lot, David.
Thank you.
Next is Mike Gaziano, who's going to talk about the Million Veterans Cohort program.